Hello guys, good evening. Okay, I hope I'm audible enough. We'll start with the session. Welcome to one more Y Conundrum. Today we'll be discussing about HIV, anti-HIV drugs. With an anti-HIV, we'll be talking about why dolutegravir replaced efavirenz in HIV regimen. Well, that's the today's question. Why dolutegravir replaced efavirenz in HIV regimen? We'll be starting with HIV. Of course, we know that HIV stands for human immunodeficiency virus. So what is the host cell for the human immunodeficiency virus? We know it's CD4 plus T cells, right? So what happens is, consider here is where your blood vessel is. We have a bigger blood vessel. Inside the blood vessel, we have CD4 plus T cells. We have two CD4 plus T cells. These are CD4 plus T cells. Now what happens is this HIV, for it to proliferate and replicate, it is going to be gaining entry into every individual cell. Once it gains entry into those CD4 plus T cells, it will start multiplying. And once the multiplication is extremely high, that will lead on to breakage of the CD4 plus T cells, thereby decreasing the T cell count. That's the reason why it is called as human immunodeficiency virus. Okay, so here what happens, consider I have drawn two CD4 plus T cells here. The HIV is gaining entry into one cell. Okay, the other cell, it is not gaining entry till now. Now, this patient has been suffering from CD4 plus T cell deficiency, and the patient is coming up to you with symptoms of HIV, and you're diagnosing the patient with HIV. Now, for the treatment of it, the first drug which we administer is named as an NRTI, nucleoside reverse transcriptase inhibitor. These are named as NRTI. NRTI stands for nucleoside or nucleotide reverse transcriptase inhibitor. Reverse transcriptase is a classical enzyme situated inside the virus because HIV is an RNA virus. It needs to be back converted towards DNA so that the reverse transcription process can actually happen, from which these nucleic acids can replicate and thereby the virus can replicate. This NRTI, for it to make sure that it is producing its action only inside a cell which is infected with HIV. How do we make sure that this NRTI gains entry into this cell, also gains entry into this cell? Are you there with me? So this NRTI can gain entry into both of these cells. First cell infected with HIV, the other cell not infected with HIV. But how do we make sure that the NRTI is producing its action only inside the cell which is infected with HIV? There, this NRTI will get activated. We keep a checkpoint, and that checkpoint is NRTI will get activated only inside the cell which contains HIV, whereas a normal CD4 plus T cell, that the NRTI will not get activated. For this activation to occur, it needs phosphorylation. For the activation, there should be phosphorylation, and that phosphorylation will be happening because of a thymidine kinase enzyme. Because of a thymidine kinase enzyme, because we know kinase enzyme is responsible for phosphorylation. So this kinase enzyme will be involved in phosphorylation, thereby NRTI will be activated, which leads on to producing its mechanism of action, that is reverse transcriptase is getting inhibited inside those cells only which is infected with the virus. Whereas it will not get activated because the thymidine kinase, the HIV specific thymidine kinase, will not be available in a normal cell. I hope you can understand what the basic difference between these two. Now comes the next step, guys. Okay, the next step is, okay, now we have started administering NRTI, and NRTI started killing off these viruses. So what this next step of resistance patterns? The resistance patterns is the virus has stopped producing thymidine kinase enzyme. That is the next step of resistance pattern. So only if thymidine kinase is there, we are going to be activating it. But what if thymidine kinase is not there? This drug will not get activated. That's the next step of resistance. How do we proceed on further? The next step here is, again, we have the same cell which is infected with the virus. Now, we don't administer an NRTI, we administer an NRTI, non-nucleoside reverse transcriptase inhibitor. This non-nucleoside reverse transcriptase inhibitor will be gaining entry into those cells only if it is infected with the virus. which means there is no need for thymidine kinase. There is no need for thymidine kinase. This drug will be concentrated only inside the cell which is infected with the virus. And thereby, we make sure that NNRTI will be producing its action only inside the cell which is infected with the virus. So we gave the first drug, which is NRTI. The virus came up with the resistance pattern, and we came up with the next drug, which is NNRTI, which is non-nucleoside reverse transcriptase inhibitor. So that is what. So for the treatment of HIV, we had a previous regimen named as TLE regimen. What is this TLE regimen? T stands for tenofovir. Tenofovir, L stands for lamivudine, and E stands for efavirenz. This was the previous regimen which we had for the treatment of HIV. Out of this, tenofovir is a nucleotide reverse transcriptase inhibitor, whereas lamivudine is a nucleoside reverse transcriptase inhibitor, whereas efavirenz is a non-nucleoside reverse transcriptase inhibitor. So we give a combination of three different drugs: nucleotide, a nucleoside, and a non-nucleotide reverse transcriptase inhibitor. Happy. That was been given before. Now came the next pattern of resistance, and that next pattern of resistance is this virus, a brilliant one, started to find out that be it NRTI or be it, I'll just highlight it for so that you can easily refer it back. Be it NRTI or be it NNRTI, the action is produced only whenever the virus is infecting the CD4 plus T cells which are circulating in the blood. We also have certain CD4 plus T cells which are there in the adipose tissue. Okay, these are the adipose tissues. Inside the adipose tissue, there is certain CD4 plus T cells. And these viruses in turn will be infecting those CD4 plus T cells. Simply, these viruses are running out from the blood vessel into those adipocytes, which contains those CD4 plus T cells. Now here comes the major issue. Be it NNRTI, be it NNRTI, or be it NRTI, both of these drugs cannot cross this blood vessel wall. This drug will be primarily effective only against those cells which are there confined inside the blood vessels. So who is going to be taking care of those cells which are getting infected inside the adipose tissue? We have to design a lipophilic agent. Lipophilic means a drug which can cross the barrier, which can cross the cell wall, which can cross the blood vessel wall, gain entry into those adipose tissues, and thereby tend to kill off those HIVs. Well, this is explained as the adipose tissue serves as a fat reservoir. For HIV. Fat reservoir for HIV. The HIV will gain entry into those fat cells or adipose tissues and tend to be concentrated over there. Well, that's how the effect is not going to be there. The resistance patterns has been very much higher. And even though we administer TLE regimen, because all of these drugs will be having very minimal penetration into the adipose tissue, thereby the efficacy of these drugs is going to be further decreased. So what we did, we came up with the third drug, and that drug is named as integrase inhibitors. This drug is named as integrase inhibitor. Integrase inhibitors are easier to remember, my dears. The drug name will be having tegravir. Tegravir, if a drug name contains tegravir, it is an integrase inhibitor. Easier. This integrase inhibitor has got a very high penetrative capacity, which means it is a highly lipid soluble agent. Now, this integrase inhibitors will be able to cross these barriers and gain entry into those cells, tend to be inhibiting those HIV, which is infecting those CD4 plus T cells inside the adipose tissue. Well, that is the reason why we have replaced this TLE regimen with the current TLD regimen. Of course, you know what is TLD regimen. T stands for tenofovir, lamivudine, and we have replaced efavirenz with dolutegravir. This TLD regimen is currently the regimen for the treatment of HIV. Now, you know why we have replaced efavirenz with dolutegravir? Because efavirenz has got lesser efficacy. Again, a why conundrum. Why efavirenz has got lesser efficacy? Because it has got decreased penetrative capacity into the adipose tissue. Why it has got why penetration to the adipose tissue is very much important? Because the HIV will be concentrating more also on the CD4 plus T cells which are there inside the adipose tissues. How do we counteract this phenomena? We replace rifampicins with dolutegravir. Thereby, we make sure that even those cells which are there infected with HIV inside the adipocytes is also going to get killed off. Well, that's it about today's Y conundrum, guys. I hope we have done justice for the topic which we have discussed for today. We'll meet up in one more session as much early as possible.